All right, I'll get started, but obviously with this working like this, I can't see anybody else, so I'm just hoping that people can hear me and that the slides move on as expected. So Wendy, I rely on you to unmute and let me know if there's a problem with the IT side of things. So thank you for all turning up, and I hope you find this a helpful session. Just to introduce myself, I'm Ollie Morris. I'm a GP. I work in Shirley in Southampton. And my interest in this area dates back to sort of several years ago when I got involved with the Healthier Together project, something I've been working on alongside for a number of years. So I'm coming from that kind of angle. And today we're looking really at assessing acute illness in children, and particularly remotely, as many of us have been doing for over kind of 18 months now, and as you do, of course, in particular, working on a clinical assessment service. So that's my background. Here's what I'm hoping to cover. So hopefully I've progressed to the next slide. Can you just confirm that that's gone through to outline for today?
Yep.
Yep, great, good. So firstly, I'm going to sort of state the obvious that we've all noticed, that there's obviously a huge increase in demand across the healthcare services for all age groups, but particularly for paediatrics at the moment. And just some thoughts about why that's happening. Firstly, confirm that that's what's happening and why it might be happening. Then I'll move on to some strategies that we can hopefully use as a healthcare service, particularly in the CAS service for assessing and dealing with this increase in demand. So focusing on the big five, the common presentations, and managing them efficiently and effectively. Making use, of course, with my interest in the Healthier Together remote assessment pathways, using the tools available there to support your assessments. And talk a little bit about managing grey areas. And by that, I mean those bits that the kind of slightly weaselly words that you can come up with that are a bit tricky to make sure that the patient or the parent has the same understanding that you do, that you've got a reasonable assessment when all you can rely on is what they can tell you. And then the third section is looking at effective safety netting. So I think that's crucial. You all know that with the kind of work you do. But I think in this area, particularly to try and manage what's going to be an increase in workload going forwards, if we can do safety netting well and not only deal with the current presentation safely, but also empower parents and educate families about how to seek help when they need to seek help and what's normal, then hopefully we can reduce this increase in demand or manage it more effectively. And a key part of that is being very specific in your safety netting. So we'll talk a bit about that. And then, as I said, I hopefully have some time at the end for any further questions you've got or any discussion about the issues raised. So firstly, a bit of a reminder of the obvious, what was different during COVID, and some of this still applies. And just reminding ourselves how much has changed since a couple of years ago. So obviously right at the peak of lockdown, families were suffering, as indeed everyone was, a lot of a loss of social contact. There were a lot of background family stresses in families. So there was a bereavement, there were financial concerns, people's employment and roles changing, even simple things like space. So some families trapped in very little space. And obviously that led to concerns of things like safeguarding, domestic violence, as well as just increased pressure on families generally. And all this has combined to cause increased anxiety for everyone, really, not just parents and children, but all of us, healthcare professionals included. There were obviously reduced presentations during the peak of the pandemic in ED and elsewhere with things like illness and injury, and there may be a couple of reasons why that occurred. And then we changed dramatically how we dealt with these things. So we were trying to avoid and minimise face-to-face contact, and we had to move whole stream to remote consulting. Again, that wasn't new for you, but obviously it was new for the rest of the health service in many cases. And then streaming people appropriately to different sorts of assessment facilities, and obviously all the use of PPE and the delays that included when you had face-to-face assessment. There were some positives, I suppose, during the peak of the pandemic. We did have a lot less incidence of infectious illnesses. There was just much less circulating, not just COVID, but all the other common things were not circulating. And there were also reductions in some of the injuries that you might see when people are out and about, road traffic collisions and sports injuries. This is just a slide, I can't remember where I got it from, but it was shared, obviously, some ED department during the middle of lockdown, just kind of for interest, seeing why children presenting with injuries. You can see that you can imagine that's probably a different pattern of people presenting peak lockdown than you would see normally and might start seeing now. It's a lot of trampoline problems as people were exercising on their own rather than necessarily sporting injuries and those sorts of things. So just to reflect that things changed quite a lot with the change in society and behaviour. I think many of us during the peak of the pandemic had could see some sort of silver linings to some of the clouds. We were thinking this might be stuff that we can try and hold on to. So I think for me, a big one was trying to avoid unnecessary journeys, realizing that actually you can manage quite a lot of stuff very well remotely, and it's not in anyone's interests, in the climate, in families and children's interest, to make long journeys across the country to be assessed for something that actually can be safely assessed remotely. I think that there was a bit about empowering parents and carers in assessing their children. So when you as a clinician are making an assessment over the telephone, just with questions that they can answer, it kind of demonstrates that you can make a safe decision without using any fancy equipment. You don't necessarily need a SATS probe or blood pressure or anything like that. And you can also show your working, so you can sort of talk openly with the family about why you think this is going on, why you're not concerned about that particular feature, and so on. And hopefully through those sorts of interactions, maybe parents and carers could understand that they didn't need to come in and be seen every time a child had a fever. I think we all appreciated or regained our appreciation of the importance of our social networks, the support that they provide. And obviously there was a lot of rallying in the middle of COVID, of people looking out for each other. And I think that was a real positive. It'd be nice to hold on to that. And then maybe there was a suggestion that we all needed to take more personal responsibility for our health, things like looking to our own exercise needs, being very careful about hygiene, self-care and self-help, trying to reduce pressure on the healthcare service, and recognising really the impact of our individual behaviour on the healthcare system and society as a whole. So all those things I think were potentially positive, and it would be nice to try and build on those. This is data taken from the STP dashboard. This is available on the Health Together website for those with kind of logins, but you can see the sort of normal fluctuation of activity. These are emergency department attendances at the different trusts in our area. And you can see that big plummet during that first lockdown in March, April last year, a gradual recovery over the summer, and then coming down again over winter, and now increasing sharply. Now this data only goes up till March. And what I would say is that since March, that uptick has just gone on and on and on, and we're increasingly seeing almost month on month the busiest months ever in the emergency department in terms of attendances. And this is all just the under 18 data, so this is paediatric data. So interesting observations. Firstly, the attendance in the ED, and these again for paediatric presentations, is almost an inverse of what you might have expected for older populations. So peak lockdown, very little attendance, and as lockdowns eased, more. This slide is maybe needs a bit of discussing. So it's just to explain what it's showing. POPS is a paediatric score. So what it does, this is from a Leicester trust, and it's just rating the proportion of patients who score POPS of 0. So what is POPS 0? 0 is for any child that's attending the emergency department whose observations are in a completely normal range. So there's nothing, their new score would be 0, and they've got no pre-existing health problems. So i.e. these are children that are not particularly unwell and we're not particularly concerned about beforehand. And what it's showing is that whilst the attendances have been increasing hugely throughout, the proportion of children with POPS 0, i.e. effectively not that concerningly unwell children, has gone up and up and up. So it's not that we're seeing a lot more children in emergency departments because they're a lot sicker, it's because we're seeing more and more less sick children. And that's the backdrop that we're all trying to work within. I think there was some optimism, probably misplaced certainly on my part, during the peak pandemic, that actually parents and carers were getting very good and very self-sufficient about managing children, and that's why we weren't seeing children. But I think actually what we probably realised is that children just weren't really getting sick because there were no viruses circulating, and actually the opposite has happened. It's not particularly that they've learnt better how to manage at home, but they just haven't had to manage with acute illnesses for a while. So I think that the sudden increase in attendance is the number of factors. There is certainly an increased and unseasonal increased circulation of respiratory viruses. There's a definite increase in things like bronchiolitis at the moment and circulation of RSV. We're also dealing, we've got to remind ourselves, with the whole new population of first-time parents who have maybe given birth just before or during the pandemic, and for much of that first year or 18 months have not really had their children moving around the community. They've not had the usual support they would have from healthcare professionals and baby groups and toddler groups and all that sort of thing. And they're really encountering illness in their children for the first time with relatively little support up until now. There is obviously ongoing social disruption and lots of stresses on families too. And all this combines to give, I think, a significant level of anxiety, but also a loss of confidence. And again, just to emphasise, that's not just parents and carers, but it's us too, to some extent, and we should be aware of that. So why are parents seeking a healthcare consultation, whether they call 111 or whether they go to the emergency department or seek a consultation with their GP? So this is a summary of some information that's kind of these couple of papers at the bottom. And essentially they're looking for two things really. Firstly, they want a proper health check. They want to remove sort of health threat to their children. And essentially what they're saying is they lack confidence to distinguish normal or not worrying self-limiting illnesses from more serious ones. And they believe that we as clinicians can make that distinguishing difference. I think the belief there is quite important. Certainly we have more training, more experience, but I think actually we should recognise that probably parents are in a good position to make these judgment calls too, and what they really need is information. And it's very much a shared care decision as to whether this child, the way it's described and the parent that knows them well, is someone that you're very concerned about, or someone that actually thinks this is pretty okay, and we just need to watch out for key features to make sure that they remain okay. But they also want information, at least that's what they tell us in these two papers. They want to know, okay, you think the child's okay now, but how will I know that they're still okay if something changes? So when should they worry? What is normal? What can they expect for that illness? And at a practical level, what can they do to look after their child, do the best for their child here and now? And this sort of information really has fed into our approach at the Healthy Together project in terms of the kind of information we're giving to parents and also clinicians to support them in their assessment. Because if we don't give consistent advice across the healthcare system, we are going to just increase that anxiety, and that's going to reduce confidence from parents and carers and just drive health-seeking behaviour further. This is old data now, but actually is pretty unchanging whenever you do it. And what it's just demonstrating is that if you stratify why children, and this is the younger age group, so 0 to 4 years old, so under 5s, why they are presented, in this case for GP consultations, but it's the same in other areas of the health service. What are the main conditions or the main features of the illness presenting? And what you see, of course, is the big one is fever. And after that, you've got respiratory illnesses like asthma, wheezy illnesses, and bronchiolitis. Then you've got reasonable thing for diarrhea and vomiting, and norovirus type symptoms, and that's a seasonal thing, of course. And then smaller presentations, but still significant abdominal pain, and finally head injury. And the point to make here is that fever and respiratory tract infections make up the vast proportion of these acute presentations. So if we focus on managing those sorts of presentations effectively and efficiently, it'll make quite a big difference to the overall workload in the health system. And things that fit outside these categories and are a bit strange, a bit more unusual, really don't sweat them. There's no problem if you spend a bit longer assessing them, if you have a much lower threshold to bring them in for face-to-face assessment, if you discuss them with paediatrics, because the numbers in these other areas are not huge. But it's quite important for us as a whole healthcare system that we've got good systems for managing these really common presentations. And that's certainly what the focus of Healthy Together was to begin with. So if we move on to what sorts of strategies we might have to help us deal with this ever-increasing workload and demand, I would suggest that there are lots of resources there. Of course, you've got your own skills and experience built up over many presentations and learning experiences. So just rely on that. But if you want extra help, then the Health Together resources are designed to help clinicians, parents, and carers, wherever you are based within the healthcare system, and there are different resources for different people to try and manage things and make decisions and look for good, reliable advice that we can all agree on across the patch. If you've used the Health Together resources, you'll recognise that very early on you try and stratify children to red, amber, green cases or presentations, and that's essentially following the NICE guidelines for feverish illness, but extended across other presentations. And what we believe and what we certainly think is that most children are going to be quite readily identified as green children. So these are children that don't have pre-existing health conditions, don't have any reason before they became unwell that you'd be particularly concerned about them, and that after asking reasonably systematically but fairly quickly across the main areas, you realise there's nothing particularly concerning about them. And for those children, I think the importance is to move on fairly rapidly, and having made that assessment, but to give a bit of time to some proper, effective safety netting and empowerment. And what we're hoping to do there is to try and make the family confident that they understand what they're doing, that they're not going to have to call back down in a couple of hours' time when something else changes, unless they really need to, and that maybe the next time the child has the same illness, they're happy that actually they can just look at that material and they don't need to call straight away. This should allow us to have a bit more time for all those situations, which should be a smaller number, where you're less certain about things. So particularly with what I call the grey areas, so these are the sorts of things where it's not very clear cut. Something like, what is the temperature? Is it above 38 or not? And how old is the child is very clear cut. Do they have a pre-existing health condition? That's pretty clear cut usually. But these sort of grey areas, like, oh, they're a bit drowsy, or they look a bit pale, or the breathing's not quite right. Sometimes it takes a bit more time to unpick what that is and what that's about. So take time for that. But as I said, fall back on your and have confidence really in your listening assessment skills. So you will know you want to avoid any assumptions. It is important at times to be quite systematic, particularly for the important negatives in the history, past medical history and things like that. And obviously trying to avoid leading questions. So particularly when you're doing remote assessment, avoiding those things those pitfalls that you're all familiar with. So a balance of open questions, but clearly and well-structured focused questions for the important points. So I mentioned briefly about grey areas. So these are some of the ones that occur to me, and we can talk a bit more about them at the end. What I would say is that they're just ones that I think worth spending a bit of time unpicking what the patient or the parent means by that, and that it corresponds with what we're interested in. So parents will often talk about noisy breathing or the child being wheezy. Now, a child being wheezing may well be just a child that's making noises now and again when they breathe, but it's not the same as what we mean by wheeze if we were able to put a stethoscope on the chest and hear actual signs of bronchoconstriction. And difficulty in breathing, well, it might be that they're having a coughing fit and the breathing's not right then, but what are they actually like when they're not coughing? So it's those sorts of questions I think are helpful. So what's the pattern of breathing like when they're settled and relaxed? What we're interested in is the effort and the forcefulness of breathing, things like recession, but obviously we're not going to use that language, but we want to get a picture in our minds of what's going on. And we're less concerned about a snuffly, noisy breathing or, a bit of spluttering at night time, that sort of thing. Similarly, pale appearance, again, often needs a bit of unpicking. It may not be particularly helpful. A lot of children look a bit pale when they're not feeling well, but you want to distinguish that from a child that's grey or blue or really quite a big change in their normal colour. So open questions like, what's their appearance like? Is their colour normal? And letting them come up with the words themselves. Cold hands and feet can be a bit of a pitfall. Many of us recognise that if you've got a child that's actually got a fever there and then, they often have shut down slightly peripherally and will have cold hands and feet. We're probably more concerned if they've got cold hands and feet when they don't have a fever. And just reminding ourselves that this is really about assessing circulation. So don't use this in isolation, but think about the overall picture. Are you worried that they might have other features of circulatory compromise? Are they breathing faster than normal? Have they not really been taking much fluids on board or losing extra fluids with a high fever? Are they passing urine frequently? So getting an overall picture, also the colour, they've got the mottled appearance you can get with poor circulation. The big one I think we find tricky are these words like lethargic, sleepy and drowsy. So I think just to I try and remind myself that what I'm doing here is to think about essentially doing a remote GCS assessment. That's what we're trying to assess, the cognitive functioning, the neural functioning in a child. And so what you want to do is use the parent or carer who's with the child essentially to do that remote assessment with you. So, how easy are they to wake? What do you need to do to get them to open their eyes? What do they do when you do that? Do they say, get off? Do they turn over and push you away, or do they just kind of make a funny vocalization and open their eyes? Obviously, it's quite different situations there, and it's important that you get a picture of how the child's responding. Right, before I go on to effective safety netting, what I was going to do is try and close sharing that thing, and I'm going to switch now to the Healthy Together website. So can I just check, and someone confirm that that's now saying the fever high temperature page of the Health Together website?
Yeah.
That's great, good. So I don't want to go through all the pathways, because obviously there are lots of different pathways here, and you may actually look at these and not find them helpful yourself, which is fine. But I just wanted to introduce what is available if you want to use it. This website is designed to be completely open and transparent to anybody who looks at it. So whether you're a child, of an age that can look at this, a parent, a carer, a doctor, a nurse, anybody, a member of the public, you can look at it. So it's all completely open. There is a bit for the professionals there. So obviously that guidance tends to be a bit more technical and jargon, and that might be worth looking at and helpful from your position. But I sometimes and often want to start with just what the parents will look at themselves. And actually a lot of the information's in there. And the advantage of using the same material that's aimed at being parent facing is that they can also see and demystify it, that you don't need to use all this jargon to make a reasonable assessment. So what I pulled up here is the page for children over 3 months, just to show you how it clicks through. So you go to children over 3 months, worried your child is unwell, and if you follow that through, you'll get to a page that's got all these different options. And the fever and high temperature is obviously one of our commonest presentations, so that's why I've picked this one. And they also use a similar format. So there's usually a bit of description at the beginning about what we mean by fever, why children get fevers, a bit of general kind of information and normalizing and maybe addressing some concerns like febrile convulsions. We've got some of these, we now have some short videos that I and Sally Hinder, who's a health visitor, put together, just really talking through what's on these pages for those who prefer to listen and watch things rather than read them through. But again, it's all parent facing. There's links to things like how to take a temperature, which links to the NHS website. And then the main bit of it, which is what we use for assessment and what we're hoping parents and carers will use, is this red, amber, green system. And we know from feedback that this is what parents really like. They like that they can go to this straight away, and they like the fact they can literally go through this and tick them off. And as they go down, firstly, the urgent things, they can reassure themselves, I don't need to be worried urgently. I don't need to be rushing to A&E and calling 999. For the amber ones, they can look in that and think, okay, maybe it is worth going to run this past a healthcare professional. I'll call my GP, I'll call 111, and that's of course where we come in. But if they're not getting any red or amber features, they can be reassured that this is fine. There's nothing to worry about in particular, and they can move on to self-care. Okay, and there's a bit here obviously about COVID stuff. And the self-care, it tells you about advice, what you can do, whether, debunking that actually tepid sponging is not helpful, using paracetamol and things like that. There's the fever and advice sheet they can download themselves, the stuff about the glass test and so on, how long they can expect the symptoms to last. So just a bit of information. So what we've tried to do is address those things that parents said they're interested in. They want to know that it's not serious, know what to look for, suggest it might be serious and how they should deal with that, and what they can do to keep their child comfortable and as comfortable they can be until they overcome that current illness. Just looking through some of these features here, just so you've got a sense of them, you can see, and a lot of these are very similar across the pathways. They're trying to pick out features of serious illness like sepsis. So obviously this is trying to pick out a child that's got particularly shut down and circulation failing. So pale, I said, is not a particularly helpful thing, but certainly that mottled, blotchy appearance is worrying. Feeling abnormally cold to the touch throughout the body, a real sign that the circulation is not working properly. Going actually blue around the lips is clearly a sign of quite severe cyanosis, and that'd be very worrying as a parent. Severe breathing difficulties, which I'm trying to make it emphasize, it's not about breathing being a bit different from a little bit noisy coughing and things like that, but actually struggling in effortful breathing, so too breathless to talk or eat or drink. Any child who has a fit or a seizure, certainly until they're known to be a child prone to febrile convulsions, it's very appropriate they get seen urgently, so that's one of the red features. This is now trying to assess sort of GCS type things, so if they're extremely agitated, and we try and expand on that a bit more, so really inconsolable crying. Now, a lot of young babies will cry a lot when they're upset, but saying that you can't really settle them at all, they're completely inconsolable and cannot distract them, or if they're actually confused, if that's an older child and you can assess that, or very lethargic. So what do we mean by that? Actually, it's quite hard to wake them. You really don't think you can wake this child or keep it awake for any significant length of time. It's behaving very differently. Then there's the rash, the non-blanching rash, and talked about glass test there. And then one of the few clear cut-offs, which is the NICE guidelines, that any child with a fever under 3 months, a temperature above 38, probably needs, well, they do need admission to hospital, and you will usually have a full septic screen, just because the risk of serious bacterial illness is higher in that age group. Then they move on to the amber features. So these are things where it's slightly a bit grayer and often want to talk through with someone. So if the breathing's not as worrying as in red, but it's not normal either, and you think they're struggling a bit more to breathe, if you're worried that they're not getting well hydrated enough, so that they've not been drinking very much, not passed urine for 12 hours, and it's got some other features there. Again, this is now a slightly trickier one, so that they're not normal, but they're not just sleeping a bit more because they're feeling unwell. So you're a bit worried that they're not quite at this level of agitation and confusion and lethargy, but somewhere in between. And I appreciate that's a difficult one and a judgment call. And that's where gaining a picture of the child as you talk to the parents is helpful. Here's a sign of sepsis, so extreme shivering, rigors, complaining of muscle pain. There's another clear cut-off temperature, so this is that intermediate risk age group, so 3 to 6 months of age. A temperature over 38, that's okay, but it's above 39, that probably needs a bit more thought around it. The only caveat there, of course, is any child that's had an immunisation and is otherwise well may often have a fever up to 2 days after the vaccination. And then the last point there is that a fever that's going on for more than 5 days. So most fevers will settle after about 5 days. They may come and go over a couple of days, so it's very normal, obviously, that it peaks and then returns to normal, and then a few hours later or the next day may come back again. But if it's going on for more than 5 days, we think that's worth seeking a healthcare professional opinion. All right, and then there's, as I said, the evidence back there. So that's what it looks like if you are a parent and carer. For the professional point of view, again, depending on where you're working here, but for the one-on-one clinicians, if you're actually doing it remotely, there are these pathways, which are the remote assessment. So we can look at the same one there just to get an idea of it. And you'll see that it mirrors this in many ways. It's just doing the red, amber, green in different ways. We do include respiratory rates because sometimes you can get a bit of sense of that over the phone. If you can actually hear the breathing or get the parent to count, that's just if you're confident about that, but also you might not get that information. But it's essentially presenting the same things in a similar layout, giving the links to the safety netting sheets as well. So if you just look at what the safety netting sheet would be like, here's the under 5-year-old of age, and you can see it's very similar to the red, amber, green that's parent facing in the first case. Okay, and they can download a PDF version, but it's the same sorts of things we've just been through, just a slightly different organisation and orientation. A really useful feature for the safety netting, I think, is this SMS share button here. So if you click on that, confirm you're not a robot, all you need to do is just type in the number of the parent, obviously with their permission, click the share button, and they'll get a text message linking to that page directly, and that's quite helpful. So that's the sort of fever one. I think the other one I was just suggesting that we look at briefly would be the difficulty breathing one, because that's obviously another really big area. So we've got that all under one umbrella here. There's a cough and cold if it's more just about those sorts of symptoms. But if we look at the difficulty breathing and wheeze, because we're going to see probably quite a lot more of that if you're not already, bronchiolitis and viral-induced wheeze is definitely on the increase at the moment. So similar sort of layout, what you can expect, what's normal, pointing out under 2 years of age, it may well be bronchiolitis and what they can expect about that. That really the emphasis is about struggling to breathe or features of croup. That's probably when it's most useful for them to be seen by us. But we're just reiterating that most of these respiratory tract infections and even chest infections are viral and are not usually going to need any or benefit from any treatment or antibiotics. You can see again some of the features here. Red features are similar across the pathways. So, you know, hypoxia, circulatory failure, decrease in GCS, non-blanching rash. These are all just common ones. But here the focus here obviously more about breathing. So there's a bit about picking up stridor, particularly stridor at rest, which is obviously a red feature of croup, needs a more urgent assessment. Whereas if they've just got stridor when they're agitated, then that's something that could potentially be seen by a GP and managed with steroids if it's okay otherwise. There are some links to other videos about what grunting sounds like and what stridor looks like if they want to. Then there's the amber features, so it's a bit more about work of breathing, stridor when they're upset, concerns about dehydration. These other ones are ones that you've seen on the previous one. So there's a bit of tweaking for the presentation, but some of them are more generic features that we just want there as a safety net in each case. Okay. Again, just to talk about, if you're, as the professional side of you can look at the same things here. Just to have a little different one, obviously the primary care staff paediatric pathways, this would be if you're a face-to-face assessment. If we can pick up one, if you know you're dealing with bronchiolitis, it's going to be slightly different. If you know you're dealing with wheeze, it's a different one. And you can just pick up any one of these pathways and they'll give you some saturation levels and pulse rates and things like that to help guide your decision making. Okay, so the last thing I was just going to say along specific pathways is, because there is a big increase anticipated in happening of bronchiolitis, NICE have actually recently just changed their guidance, and we're in the process of developing some new guidance for Health Together on managing that to reflect those changes. And essentially the changes are that we are now tolerating lower levels of saturation for bronchiolitis because there's good evidence that that's perfectly safe to do so and doesn't alter outcome. So just to share what that is, just to emphasize that this is not yet completely validated, not available on the website, but we're in the process of finalising it now and will be available soon. So this might be helpful when it's finalised. So this is about cough and breathlessness for any child under the age of 2, aimed in primary care, but also can be used, in one-on-one, any other setting. It is based on people who might be able to do a face-to-face assessment, but also you can adapt some of this to remote assessment. And it's trying not to worry about a particular diagnosis here, but just look for red, amber and green features. So the main difference here is that it's what's helpful in the second page is it gives us a bit of a reminder about what makes us think it's more likely to be bronchiolitis and what makes us think it's more likely to be viral induced wheeze. The benefits of that are essentially that there are different treatment options. So for bronchiolitis, it's now very well established that bronchodilators, ipratropium bromide, all those sorts of things just don't help at all. So don't give them. Obviously, for viral-induced wheeze, it can be helpful to give bronchodilators. So there's an important difference there. The other difference is that if we're confident that it's bronchiolitis, we can tolerate lower saturation level. That's what the NICE guidance tells us now. So NICE would say that actually it's safe to discharge or not admit children to hospital if you're confident it's bronchiolitis and they've got other features that are okay, providing that saturations are above 92%. Or 90% in some cases if they're otherwise fitting well, but 92%, particularly if they're under 6 weeks. So if I just go and bring up that at the moment, we'll cover that a bit later. So that hopefully gives a bit of an advice, and obviously there are links through the individual condition-specific pages here, but the advantage of this approach is you don't need to have a diagnosis to begin with. You can come up with a sort of severity grading, come up with sort of action, and then look at the specific pathways for the guidance for how you manage them. And I think this second table I find quite helpful to remind me about features in the history that are going to help me A, be concerned, and B, work out whether it's more likely to be bronchiolitis or viral-induced wheeze. We do think this year that there are going to be more episodes of bronchiolitis in children above the age of 1, so in that 1 to 2 year age group, and that's because they haven't had the opportunity to pick it up before now. Usually we'd say bronchiolitis is mainly under the age of 1, although it can always be up to 2 in the past as well, but there's going to be more of that slightly older age group. Right, I'm just going to stop sharing there and come back, sorry, to the main file. Okay, so the last bit I wanted to talk about was this business of effective safety netting. So certainly when I started out in medicine and was training as a trainee, I was very much, my safety netting was if anything gets worse or if you're worried at all, just call us back, or call 111, things like that. And I think that that's not really very helpful, because it all means what we mean by getting worse. And for some people, it's quite reasonably, if the fever comes back, they've got worse. Yet we know full well, of course, that a temperature will come and go, and that in itself is not concerning. So I just think the important thing about safety netting is to be as specific as we can be. And that is, what actually look out for, think about what the alternatives could be for the diagnosis and what things would be worrying. And then equally important is what to do about it. So there's a big difference between, right, you need to call 999, get an urgent ambulance, or you need to go straight to the emergency department, versus you need to call 111, or you need an urgent appointment with your GP, or maybe even you just need to arrange a routine appointment with your GP. And I think it's important to try and encapsulate that in our safety netting advice. And the Healthy Together safety netting sheets are really designed to help with this. So they are, that's what the red, amber, green does for you. So the red is very much any of those things happen, you go straight to the emergency department or call 999. The amber is you call 111 or your own GP, and the green is you don't need to do any of these things. You can just follow the advice on the web page, and that share function makes it easy. So I think, from my perspective, I increasingly spend more time on trying to do safety netting thoroughly, and less time on assessment once I've done enough to satisfy myself the child's okay. And I think it is worth, even in those sort of straightforward cases that you think, oh, this is a quick one, I've dealt with that, and get on to the next case, maybe just taking a few extra moments to do that safety netting effectively might help us all out in the longer run, by supporting families to make appropriate, helpful decisions in the future. This is just to demonstrate the impact of these sorts of approaches. So this was a study done a few years ago now by Seb Gray, who at that time was a paediatric registrar at Southampton. And what they were doing, this is the paediatric assessment unit there, has always had this system whereby a child that's discharged, they have open access for the next 24 hours. So if anything the parents are worried about in the following 24 hours, they can just come straight back to the paediatric assessment unit. They don't need any other assessment. They can just represent and say, look, this has happened. And what they did is they did some systematic sort of education of the staff, of the new safety netting sheet, using the materials and the Health Together, and really pushed doing that for every discharge. And what you can see is that over the following weeks, there was a quite significant decrease in the amount of representation. And each of those representations, there's obviously quite a lot of, the child needs to be re-seen, re-clarked, talk to the family. Just think about the effort and the disruption for the family and the child involved, going back into hospital, all of those sorts of things. So every one of those prevented representations is worth doing. And certainly there's no evidence that this corresponded with poor outcomes for children. These were very safe loss of representations. Across the system, here's some data just showing over the past few years. Again, we haven't got the latest year because that's been a very unusual year, showing that at Hampshire overall, and this is emergency admission rates in under 18-year-olds, we do pretty well compared to England. The important bit that we'd like to point out is that not only are we sort of better than the England average, but overall we've been increasing that difference as time goes on. And we'd like to think that some of this is the efforts of things that you've all made in good safety netting, using material and empowering parents to make the right sorts of decisions. Just to go through these bronchiolitis changes to make sure I've given you the right information. So essentially, if you've got a child that's got no comorbidities, they're not premature, they've not got heart problems, immunodeficiency, things like that, they're over 6 weeks, the NICE guidelines now say that you only really need admission if they're below 90% oxygen saturation. And that's obviously maybe significantly lower than you're used to. Just bearing in mind this is a child that's still feeling okay and that you've not got other things that concerns that they needed admission for. Obviously, when you're a lot of the time, if you're doing assessments remotely, you're not going to be able to assess saturation. But I think it's just important to recognise that sort of shift in perspective, that there's a recognition that if we have all children with bronchiolitis who are in hospital only because their SATs are below 92%, we're just going to overload the system without any benefit to anyone. At least for all the children and the families themselves. And just to say that there will be new resources to be released soon to help us with those changes. And there's a piece of work of communication going out to primary care at the moment to spread that across the system. I think that's all I wanted to do. It's sort of 42 minutes or so into this session, and I'd rather leave time for questions and discussion, just to demonstrate, obviously, I'm a very small part of a bigger team. That's me in the middle there before I grew my beard. On the left is Sanjay Patel, who's the infectious disease lead at Healthy Together and has really pushed the whole project. There's Holly Green, who runs the maternity side of things. At the bottom, you've got Andrew Stanley in the middle, who's the project director. David James on the right, who's the emergency consultant, and he's done a lot of the work with 111 and doing the remote assessment pathways, and there's a series of videos on how to use them that he's put together. And bottom left is James Edelman, who rolls out the sort of education programme, particularly amongst primary care. So thank you very much for your interest in being here. I'm just going to stop sharing now and hopefully open up to any discussion questions. So I think probably because there can be difficulty with the echoes, if people want to just put in the chat or put their hand up, and then I can choose people, you can unmute or do what you want. So Maria Carey, hello.
Hi, I would just like to say that I've been using Healthier Together for years now. I was a GP in partnership for a long time and retired 5 years ago and just carried on doing out of hours. Sending those SMS safety netting sheets for ages, and they're really exceptionally good, and they make me feel more confident, and I'm sure it make the parents they're a lot more confident. And often I do send them, I actually then ring them to make sure they've actually got it on their phone. Because the thing to share is that when you do an SMS from your mobile, it doesn't give your phone number out. I need to worry about that, but I will look at it again because there's obviously been some changes the way the layout.
That's nice. So very nice to have that feedback. Your piece of looking at it again, I always feel a bit embarrassed that I'm meant to be involved with this team, and each time I look at the website, there's material I feel I didn't know was on there. So it's got really quite a lot bigger.
Well, I've been using the GP professional site and then cross-referencing on my red, amber, green on another tablet. But actually, I look at that clinician out of our site because that's all amalgamated there, isn't it?
Yes.
So have a look.
Yeah, and I think that, so I think the point about the SMS share, I agree, it's really a nice tip to say, check they've got it. So either send it, as I've done it sometimes, and I've got it through now. So actually, as you're on the phone, you can send it through and they've got the ping. And I think the bit about, yes, maybe reassuring them that, it's all they're going to get is a link to a website. There's confidentiality, that their mobile number's not being sent out into the ether or anything like that. That's a really useful point as well.
But also from your own point of view, I think a lot of GPs or clinicians don't want to be sharing their mobile number. So people are frightened to send it, SMS it, and they'll be ringing them up some other time, which they won't be. No,
that's true as well. And the other thing I found is that just as a point of process, when I'm now documenting my safety netting rather than write down, because I think it's important we do that specific stuff, I will just put worst advice given as per HT, Health Together, cough and cold. I think, and I'd rather spend the time, instead of typing it all down, on actually talking it through. So it's not enough just to share it, you want to actually talk through it and then support it with a share.
I do that as well. Yeah, I just SMS, because otherwise you're just duplicating it and wasting loads of time. I understand that in terms of safety netting stands up in the court of law if you put that.
Yes, I think if you say that I've done my standard thing and it's clearly what you've referenced it to and that's what you've done. Okay. Anybody else got any questions or comments, queries?
I mean, the only thing I'll make again, sorry, is that there are a lot of people who are reluctant to use it. I have to say, because I mentioned it to people at PHL. I work at Basingstoke as well, but it's slightly different. It's more sort of GP led, but a lot of the urgent care practitioners or other clinicians are a bit nervous about using it. They don't really know whether they feel they're allowed to use it is one of the issues, I think. And I think personally, PHL should be pushing it.
So I think so I spent some time, a little bit of time being a clinical supervisor on the paediatric desk in June. And the difficulty there is obviously you have to use pathways to some extent, and even that sitting in a clinician module, and it's got its own inbuilt safety netting system, which I personally do not think is helpful or as useful as the Health Together. So there's a bit of a constraint there about what you've got to do to keep the computer happy and your audits happy, and what I think is effective in terms of.
I put in a free text. And I think they just changed that module. They changed it to another system now. Just they've got like to PACS, which I don't think you have to go through some of it, but I think there's no reason why you can't go through some of it and tick some of it, but you can also put separately in your own note where you type your history and presentation. You can put at the bottom that you have done this. But maybe they need to build something into the system whereby you can just tick. I don't know.
Yeah, I think there'll always be a difficulty with that because pathways and obviously the system is a national thing, and Health Together isn't national, although increasingly places elsewhere in the country are taking it on board. But I think that you should feel confident that all the Health Together pathways are developed across Wessex. So you've got paediatricians, all the trusts signing off these pathways that they're happy with them and they've been used. And when we first started using these, there was some trepidation. Are we setting the thresholds right? Are there going to be some adverse outcomes? But as time has gone on, so they've worked very well. A bit, I mean, we've all got that anxiety about the child that slips through the net, and unfortunately those things are going to happen. I mean, there are horrible illnesses out there that, despite everybody's best intentions, and it's not negligence, it's not poor clinical assessment, it's just bad stuff will happen. We want to try and minimize that, and it's important to keep those in mind. There's brought to my attention an example recently of a child actually in our practice that was assessed through the 111 service. And so this was a child with no previous health problems or concerns, presenting in a very typical way with a fever, a bit off thing, not quite right, not very clear focus, maybe inerty, had been assessed by 111, sent appropriately to be assessed by their local face-to-face provider, seen, assessed thoroughly, documented, safety netting, called back later on in the evening, by which time we want to view lot, at 10 o'clock at night with limited options, and really hard to put it on. It was that lethargy thing. They're just not right, doctor, they're drowsy. And, whoever did that assessment, there must be something out there. And they made absolutely the right call. They said, I think you need to go into hospital. And interestingly, this child went into hospital, and even on arrival in the hospital, obs are absolutely fine, blood's okay. Did seem a bit drowsy, but by that time, it's a young child, they've been up all day, it's 11 o'clock at night, let's give them the benefit of the night, observe them overnight. Following morning, no, really, they're not waking up properly. And they had, streptococcal meningitis, and, but how are you going to pick up that child? It's really hard.
Oh, no.
And I think the thing was it was actually, if you looked at it, they were following very closely what was going on, whether intentionally or not. I don't think they were necessarily using the healthcare guidelines, but they were thinking, the worry here is this child's consciousness. And the parents consistently worried about it. They've seen someone today, and a few hours later, they're still worried. And they've had very good safety netting, very good instructions. They need to be looked at again.
We had a child like that years ago, and I did a bit of paediatrics in the 80s. And we had a very simple rule, actually, was if a child presents 3 times, you send them in on the 3rd time because you're missing something.
Yeah.
And the child that got sent in, because I think it was actually a GP trainee then that sent them in, because I think they were worried they might have rubella or something at that time, and they wanted this rash looked at. And there'd been the 3rd consultation this child had. And I remember the registrar saying, who was actually a consultant locally as a registrar, saying to me, "Oh, there's nothing much wrong with this child. It's just got a viral illness, but we'll keep him in at night." And then we got crashed bleat to the ward 4 hours later, and the child had meningococcal meningitis.
Yeah.
And I think that GP training purely. The child wasn't particularly ill when they went in, but she went on the principle. The parents are worried it's the 3rd call.
Yeah.
Have to do something else.
Yeah. So we have these kind of 3 strikes and you're out, these sorts of things, which are helpful. But I think what it really goes to emphasise is this idea that parents might have, that we as clinicians have some magic crystal ball that lets us know this child's sick or not. We just don't. And if you can, it's not get it wrong, but if the illness can present in that way, for me, it just emphasises the most important thing is whoever is there at the moment, recognising when there's a clear deterioration. And the fact is, most of these people are children with their parents, and they're the ones who are going to notice. So that's why I think in many cases, a child's better off with their parents at home who know what to look out for than sitting in a busy ED department where the parents relax their guard because they think we're in a safe space, and the child's getting sicker and sicker in the corner, and the whole department's too busy to really notice it. They haven't had their obs done yet, and all the rest of it. So that's why I think there's a real emphasis on empowering parents' safety netting, because even in hospital with regular obs, it can take time before it becomes clear this child's really unwell. But the solution then, of course, is not to send everybody to hospital just in case, because that just makes the situation worse.
Yeah. Interesting. Yeah. So I think at Basingstoke, if you triage someone you're worried about, of course, there's all the issues, because there you have to be the triaging doctors overnight, triaging doctor, visiting doctor, and see people in the clinic. So if it's busy and it's just you, it can be pretty hard work. But with COVID and everything, then became a problem with can't bring anyone down to surgery with temperatures. So then it became, do you visit these children at home with temperatures? And they policy to keep them out of A&E at Frimley. That and I think they did the same thing at Basingstoke, that actually if you thought this child needed admitting, you couldn't send them away. You actually had to get the paediatric registrar to accept them. You had to do it like an admission over the phone without seeing them, which is quite interesting. But then I think that child isn't sitting waiting in A&E. The registrars are aware they're coming in.
Yeah.
In some ways, that's actually better than just sending to ED. Although the nice thing about ED now is you can make appointments in ED for some people. That's about the thing I've learned to do.
Whether they can keep them, of course, is a different issue when it's so busy.
Jodie, oh yeah.
I see that you've got your hand up. Is it all right, Maria, if we move to Jodie, because I think she's got a comment or a question?
Yeah, I just wanted, so we're using, I'm on the paediatric desk at PHL, and we're using the Help You Together now more for all of our stuff. And we're also using Good Sam, so we get to see them on video as well. So using that alongside Health You Together, I think is really helping, especially with the respiratory stuff coming in at the moment, and rashes as well. So it's helping with that. But yeah, and obviously we've got the new packs, which is a lot less clicky, and allows us, it's easier given we just, I do like you say, just put in that I've given advice on Health You Together, and I just attach the link just to show what I've done rather than go through. There's not as much safety netting stuff on there now, so we can give them more relevant stuff from Help You Together, which is really good. So
great, Joan. It's good to hear from you. I recognise your voice from yes, but it's really good to hear that firstly that Good Sam is up and working. You've got the video things. I think that does make a difference. So yeah. I interestingly, we all moved to video, or had the availability of video in primary care quite early on in the pandemic. A massive change. It was really great. It's interesting how it's not that often that I use it. I thought I was going to be using it all the time for paediatrics, and what it told me is that actually, if you spend a bit of time, you can make quite a good assessment just verbally, but it is really helpful sometimes to just have that picture. You learn so much. You suddenly see what their child's doing in the background, particularly if it's, oh, they're really drowsy, doctor, or they're not right. When you actually see them, you can make a more informed decision, can't you? So I think that's really helpful. And it's good to hear that the things are a bit more streamlined in terms of the IT side of things, because that was a bit tricky.
Yeah, definitely.
Great. Anybody else on the call who's got a query or question, feel free to put it in the chat if you'd rather just do it that way, or anything that you'd like me to go over again or talk about or look at. Otherwise, we're pretty much coming up to the hour. So I think I should probably let you busy people get off and carry on with work, or more importantly, some well-earned rest if you've got free time this afternoon.
Thank you.
Thank you.
That's great. Thanks very much, everyone.
Thanks a lot.
Bye.
Bye.
Thanks, Ollie.